We'll invite up Dr. Karen A. Howell from Banner UMC in Tucson, Arizona, to present the association of loss of commercial insurance and the risk of lower extremity amputation in peripheral artery disease.
Good afternoon, everyone. My name is Karen A. Howell, and I'm a vascular surgery resident at the University of Arizona. Today, I'll be presenting a talk entitled The Association of Loss of Commercial Insurance and the Risk of Major Amputation in Peripheral Artery Disease. We have no significant financial disclosures. Peripheral artery disease is highly prevalent in U.S. adults. Over 6.5 million adults over the age of 40 have PAD. We know that PAD increases risk for lower extremity amputation. In hospitalized patients, these rates approach 6.8% at 1 year. However, in community ambulatory populations, these rates are lower, and in the chronic limb-threatening ischemia population, they're higher. We also know that multiple socioeconomic factors increase the risk for amputation in our PAD patients. Certain minority races, including African American, Hispanic, and Native, as well as those in the lowest income quartile, those who are underinsured, such as on Medicaid, or lack insurance completely, and those who live in rural zip codes are all at increased risk. We don't know what happens in a previously commercially insured population. In this study, we aim to analyze the relationship between loss of commercial insurance and risk of limb loss in a previously commercially insured PAD population who goes on to lose their insurance. We used a large insurance claims database. We hypothesized that PAD patients who lose access to commercial insurance and switch to either cash pay or Medicaid are at increased risk of limb loss. We used a retrospective cohort design, and the two cohorts consisted of those with 3 years of continuous commercial insurance and those with commercial insurance at the start of the study period, but loss of insurance at some point during the period. We used theirs 2010 to 2019, but patients did not have to have data for the entire period, only a three-year segment. Our primary outcome was major amputation above or below knee, and secondary was minor amputation at or below the ankle. We excluded those under 18 or those with a prior amputation on either leg. For this project, we used the Pearl Diver database. Pearl Diver is an all claims insurance data set, and it's a fee-based tool for researchers. It includes both the data set and a built-in statistical analysis software. It includes 91 million unique patients and includes those on commercial and government insurances, as well as those who pay cash. It includes patients from all U.S. states and territories and actually tracks patients who move between states or between hospitals within a state. It is CPT code based, and it's been frequently used in health economics research projects. Demographics were assessed with chi-squared test, and demographics and outcomes were assessed with Kaplan-Meyer curves. We then performed both a univariate and multivariate logistic regression. We did this on a Crude cohort and then a propensity matched cohort as well. The propensity matched cohort was taken as a subset of the overall cohort, and we matched for age, gender, and Charleston Comorbidity Index. It was done on a one-to-one basis and used an algorithm to try to create the lowest scores between the matched participants. This flowchart shows our patient selection process. We began with all PAD patients based on CPT codes, greater than age 18 with no history of prior major amputation, and actually polled over 2 million patients. We then excluded patients who switched to Medicare or other government insurance such as the VA. This left us with a set of over 550,000, and we then excluded patients who did not have 36 months, the 3 years of continuous data, or who didn't have 6 months of continuous commercial insurance prior to the point at which we enrolled them in the study. This left us with 214,000, slightly more in the loss of insurance group at 121,614, 92,772 in the continuous group. We found that patients in the loss of insurance group were at a significantly higher increased risk of limb loss, both for major amputation and on minor amputation. On univariate analysis, the odds ratio for major amputation was 2.96, and the odds ratio for minor was 2.476. In terms of our cohort demographics, the ages were roughly what you would expect. Most patients were presenting in their 50s, 60s, and 70s. In the LOI column, you can see that over age 70, there's significant dropout, likely due to patients over age 65 transitioning to Medicare who were excluded from the study. In terms of gender, we actually had a surprisingly equal amount of men and women in both branches. The CCI refers to the Total Charleston Comorbidity Index score. This is a well-validated tool that looks at common health comorbidities in the adult population, including hypertension, obesity, diabetes, and several others relevant to our patients. Most patients in both arms were in the 0 to 4 range, meaning they had fewer than 4 comorbidities. A few were in the 5 to 9 range, and very few had greater than 10 comorbidities. Results were significantly different between both study groups, and this may have to do with the fact that since we had such a large N size, it was able to detect very small differences. This shows a breakdown of the Crude cohort comorbidities. They're typical vascular disease comorbidities that you would expect, like COPD, renal disease, obesity, hypertension, and heart disease. Once again, these were actually significantly different between each cohort, potentially due to the large sample size. This was why we did the propensity matching. This is the Kaplan-Meyer curve for the Crude cohort. On the left-hand side, you can see the major amputation-free survival, and on the right-hand side, minor amputation-free survival. The blue line represents the loss of insurance group. You can see that it's significant in both graphs, with the log rank P of less than 0.001. We then performed multivariate analysis to assess for which other variables were significant. On multivariate analysis, the loss of insurance group still had an odds ratio of 1.77, indicating a significantly increased risk for major amputation. The other significant variables included chronic kidney disease and renal failure, coronary disease, depression, diabetes, hypertension, and tobacco use. Age, CCI score, COPD, cerebrovascular disease, chronic pulmonary disease, obesity, and liver disease were not significant on multivariate analysis. In terms of minor amputation, we've had similar findings. Once again, the loss of insurance was significant with an odds ratio of 1.41, and there were similar comorbidities that attenuated that. For minor amputation, male gender was significant, as well as obesity. Otherwise, the two minor and major amputation were identical in terms of the comorbidities that were significant. This shows the Kaplan-Meyer survival curves in the propensity-matched cohort. Again, on the left is major amputation-free survival, on the right is minor amputation-free survival. The loss of insurance group is the blue line, and you can see that they have decreased amputation-free survival. This had a significant log rank for both major and minor. In the matched cohort on multivariate analysis, we found that the loss of insurance group had an odds ratio of 2.34. Significant variables were chronic kidney disease, coronary disease and heart failure, depression, diabetes, end-stage renal, and tobacco use. We had similar non-significant variables in the matched cohort. This is the risk of minor amputation in the matched cohort. The risk was even higher for the loss of insurance group at 2.04. In summary, loss of commercial insurance is associated with increased risk of major and minor amputation in PAD patients, with odds ratios as shown below. The results were confirmed in the propensity-matched cohort. Other significant risk factors included male gender, renal disease, diabetes, heart disease, depression, and tobacco abuse. This implies that loss of insurance significantly impacts access to care. This could be related to both specialty and primary care coverage or other social or economic stressors that we weren't assessed in this study. PAD patients need consistent coverage, and PAD providers need awareness of the social determinants of health in this population. This was a relatively clean data set that captured patients at the first point the PAD diagnosis code appeared in the record. The limitations include the fact that this was purely quantitative. We don't know why patients in this data set have loss of insurance, and that could include a next step. We also don't have data on race and ethnicity due to CMS guidelines. The Pearl Diver database doesn't collect this information. I'd like to thank my mentor on this project, Dr. Tan, and the VESS members, and I'd like to open the floor to any questions. Thank you.
This paper is open for discussion. I think we have time for 2 questions.
Hi, Matt Smeds from St. Louis University. Very interesting talk. We actually did the exact opposite of what you did. We looked at rate of amputations in people who had gained insurance after the Affordable Care Act came into play. Did you find that patients were more likely to lose insurance prior to the implementation of the Affordable Care Act in your series?
We actually didn't look at that in this paper. That would be a good idea for something to look at next, but we didn't break it down into the before and after Affordable Care Act for this paper.
Misty Humphreys from UC Davis. I just had a question. I was listening to your methods, and I may have misunderstood them, but you use CPT codes to identify these patients. So these are all patients that have undergone some revascularization, or some type of procedure to get them into your cohort?
Not necessarily. They could be hospitalized for other reasons, and then the diagnosis of PAD was made during that hospitalization, but they didn't necessarily undergo a procedure related to that.
Have you thought about using ICD-10 codes so you can make sure you're having ipsilateral disease and ipsilateral amputations?
That's an interesting question. I don't know if the Pearl Diver database includes ICD codes. I would guess that they do. They have a lot of financial related information, so we could look into that in a later study.
Dr. Bush.
I'll talk fast. Congratulations. I have to rise on every amputation paper that you have here at this meeting. I'm not familiar with this data set, and so my question to you is, what is the lag time for getting complete data in it? Because what I would challenge you to do is, we do have a time period where there might be more loss of insurance, the pandemic. So I would challenge your group to look at, pre-March 20 to after March 2020, because I think there's a lot of people who lost insurance because they lost their jobs and for many other reasons. So again, congratulations.
Absolutely. That was one of the impetuses for this study. Thank you.
Thank you, Dr. Howell.